Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 446 of our pharmacotherapy series, which majors in colorectal cancer. The first case reads, OBS, a 35-year-old woman, recently learned that her 58-year-old father was diagnosed with colon cancer. OBS is obese and smokes a half-pack of cigarettes per day. She loves eating out and spends most of her evening watching TV at home. OBS would like to know the risk factors for colorectal cancer. She would also like to know whether there is anything she can do to reduce her risk of developing colorectal cancer in the future. So my question to you is, what is your opinion? OBS is at an increased risk of developing colorectal cancer given her family history of colon cancer. In addition, she is obese, lives a sedentary lifestyle, and smokes. She eats out, but no information is given about her diet. There are modifiable risk factors, which she could address to lower her risk of developing colorectal cancer. OBS can lose weight through exercise and adopt a high-fiber, low-fat diet. In addition, she can stop smoking, which can help reduce the risk of colorectal as well as other cancers. OBS would like to know whether there is a way to screen for colorectal cancer. If there is, does this method detect cancer early? Her father had a colon cancer diagnosis. Therefore, OBS wonders when she should get screened for colorectal cancer. Colon and rectal cancers are among the few cancers that can be prevented by removal of precancerous tissue. Therefore, early detection is crucial. As described above, formation of colorectal cancers is a multi-step process, and the early precancerous tissue is identifiable and can be removed. Colorectal cancer is not always asymptomatic, but early detection of colorectal cancer through screening has been proven to reduce mortality. A variety of screening methods exist, including fecal screening tests, digital rectal examination, barium enemas, endoscopy, and CT colonography. Fecal screening tests are designed to detect occult blood in the stool and are relatively inexpensive and non-invasive. There are two main types: the fecal occult blood test, abbreviated as FOBT, and the fecal immunochemical test, abbreviated as FIT. The fecal occult blood test been shown to reduce mortality from colorectal cancer by 33%. But the test does require diet restrictions prior to sampling. The fecal immunochemical test uses antibodies to detect hemoglobin or other blood components and, compared with fecal occult blood test, has no drug or food interactions. Screening guidelines acknowledge that fecal immunochemical test may be more sensitive than fecal occult blood test. However, neither is preferred over the other, possibly because of a lack of mortality data with fecal immunochemical test, along with potential cost or out-of-pocket difference between the two tests. Endoscopic screening for colorectal cancer includes either flexible sigmoidoscopy or colonoscopy, and both offer the ability to remove polyps and obtain biopsy samples during the procedure. The advantages of sigmoidoscopy are that no sedation is required. A simple preparation, 2 fleet enemas, is used, and it can be performed in various settings. Patients may choose flexible sigmoidoscopy over colonoscopy if they do not want to go under sedation or undergo an extensive bowel preparation. Sigmoidoscopy has been shown to reduce incidence of colorectal cancer by 33% and mortality because of colorectal cancer by 43%. However, flexible sigmoidoscopy allows for examination only of the sigmoid colon and rectum, while colonoscopy examines the entire colon. As such, colonoscopy is the most widely accepted screening tool. It has been shown to reduce the incidence of colorectal cancer by 77% and is associated with significant risk reduction in both right and left-sided colon cancer incidences. A relatively new method known as CT colonography provides 2- and 3-dimensional images of the colon. As with endoscopic procedures, it requires complete bowel preparation to remove feces from the intestine. This screening technique has demonstrated an approximate 80% sensitivity to detect polyps larger than 6 mm in size and 90% sensitivity for polyps larger than 1 cm. However, any cancerous lesion detected will ultimately necessitate an examination by colonoscopy. Carcinoembryonic antigen, abbreviated as CEA, is a tumor marker that is detected in the blood and has been evaluated as a screening tool, but its primary utility is in monitoring response to treatment and not screening. Healthy smokers are likely to have twice the carcinoembryonic antigen level compared with non-smokers. Further, administration of therapies given for metastatic colon cancer can cause false elevation of carcinoembryonic antigen without disease progression, so even in monitoring response to treatment, it is only used in conjunction with other modalities. The American Cancer Society, the U.S. Multi-Society Task Force on Colorectal Cancer, and the American College of Radiology have jointly published screening recommendations for the early detection of colorectal cancer. According to their recommendations, any man or woman at average risk of developing colorectal cancer should begin screening at age of 50 years. Patients at average risk of developing colorectal cancer will not have genetic predisposition or history of a family member with colorectal cancer. In addition, patients in this category will have no history of polyps, previous history of colorectal cancer, inflammatory bowel disease, chronic ulcerative colitis, or Crohn's colitis. OBS is a 35-year-old woman with a first-degree relative with a diagnosis of colon cancer at the age of 58. It is less likely she would develop colorectal cancer through a hereditary syndrome because her father was diagnosed after the age of 50. She does, however, have nearly double the lifetime risk of developing colorectal cancer because a first-degree relative had colorectal cancer. Because OBS's father had colorectal cancer diagnosed before the age of 60, she is at increased risk for developing the disease and should consider initiating a colorectal screening program at the age of 48 or 10 years earlier than her father was diagnosed, at age 58. The next case reads, BSR is a 66-year-old white man who was in his usual state of health until recently. when he decided to visit his general practitioner owing to progressively worsening gastrointestinal symptoms, including abdominal cramping and changing bowel habits. He admits to also having some blood in his stool at times, which he attributes to his hemorrhoids. His family history is notable for a paternal uncle with gastric cancer. He occasionally drinks alcohol and has never smoked nor used illicit or recreational drugs. On physical examination, he is a well-nourished, well-developed man who is febrile, alert and oriented, and in no apparent distress. He has no palpable masses and no hepatomegaly, and his abdomen is soft and non-tender with normal active bowel sounds. The rest of his review of systems is unremarkable. His performance status is excellent. He does have a history of type 2 diabetes mellitus and hypercholesterolemia, which are both controlled on his current medication regimen. His vital signs and laboratory values obtained are as follows. His blood pressure is 108 systolic, 71 diastolic. He has a heart rate of 95 beats per minute. The respiratory rate is 18 breaths per minute. He has a white blood cell (WBC) count of 4.8 times 10 power 3 cells per microliter. His hemoglobin levels are 11.6 grams per deciliter. He has a hematocrit of 35.1% and a platelet count of 208 times 10 power 3 cells per microliter. His total bilirubin is 0.3 mg per deciliter. His serum creatinine is 0.8 mg per deciliter. He has a blood urea nitrogen of 15 mg per deciliter. His alkaline phosphatase is 61 international units per liter. His lactate dehydrogenase is 366 international units per liter. He has an albumin of 4.2 grams per deciliter. His hemoglobin A1C is 6.2%. So my next question to you reads: are any of the symptoms that BSR is exhibiting associated with colorectal cancer? Although the symptoms BSR is describing are nonspecific in nature, the changes in bowel habits in addition to the blood in his stools are symptoms associated with the development of colorectal cancer. Given his age, symptoms, and lack of prior cancer screening, additional workup is warranted with one of the screening modalities mentioned earlier in this chapter, preferably colonoscopy. After a colonoscopy, BSR is found to have a moderately differentiated adenocarcinoma of the colon lying 18 cm from the anal verge invading through the muscularis propria with lymphovascular invasion and involvement of 8 of 25 regional lymph nodes. A CT scan of his chest, abdomen, and pelvis shows no evidence of metastatic disease. A baseline carcinoembryonic antigen level of 8.0 nanograms per milliliter. The normal range is 0 to 3 nanograms per milliliter for non-smokers and 0 to 6 nanograms per milliliter for smokers, is reported. My next questions to you read: after surgical resection, would BSR benefit from adjuvant chemotherapy? Which chemotherapy agents or regimen gives BSR the best chance to avoid a future recurrence? Historically, fluorouracil, also known as 5-fluorouracil and often abbreviated as 5-FU, a fluoropyrimidine, combined with leucovorin, was considered the standard chemotherapy for adjuvant treatment of stage 3 colon cancer based on studies that showed both an improvement in disease-free survival, abbreviated as DFS, and overall survival, abbreviated as OS, over no chemotherapy after surgery. For patients with stage 2 disease, only those with certain high-risk features, tumors that were adherent to or invaded other organs, were obstructive, or in patients that experienced bowel perforation, appeared to gain any benefit from fluorouracil, leucovorin given after surgery. Leucovorin stabilizes the binding of an active metabolite of fluorouracil known as fluorodeoxyuridine monophosphate to its intracellular target thymidylate synthase, ultimately enhancing the cytotoxicity of fluorouracil. Fluorouracil is administered primarily in two different ways: as a bolus injection over 3 to 5 minutes, and this is followed by a continuous infusion over 24 to 46 hours, depending on the regimen. Single-agent carpacetarbine, an oral prodrug of fluorouracil, offers convenient administration and is as effective as intravenous fluorouracil modulated with leucovorin. At present, the combination of fluorouracil and leucovorin or carpacetarbine monotherapy are the preferred adjuvant regimes for stage 3 colon cancer for patients that are over the age of 70, because this population does not seem to benefit from the addition of other cytotoxic agents to this fluoropyrimidine backbone. For patients younger than 70 years of age, the addition of oxaliplatin, a platinum agent, to the fluoropyrimidine backbone, either carpacetarbine alone or fluorouracil with leucovorin, is considered the current standard of care in the adjuvant setting for patients with stage 3 disease, because several landmark trials have shown the addition of oxaliplatin in this population can improve both disease-free survival and overall survival over fluorouracil and leucovorin alone. The increase in disease-free survival and in overall survival with the addition of oxaliplatin was less pronounced for those patients with stage 2, node-negative, disease, and so the use of oxaliplatin in this population is controversial. There were several fluorouracil and oxaliplatin regimens historically used in clinical practice. However, more current practices recommend that when combining fluorouracil with additional cytotoxic agents, the infusional modality be primarily utilized rather than bolus, that is IV push, regimens to maximize efficacy while minimizing toxicity, although the infusional regimens do still contain a small portion of the entire fluorouracil dose given as an initial bolus injection. As stated, oxaliplatin may also be combined with carpacetarbine as the fluoropyrimidine backbone. This is considered equally effective to the combination with fluorouracil modulated with leucovorin, with the main difference seen in toxicity patterns. Carpacetarbine is given orally typically as a twice-daily dose for 14 days of each 21-day cycle. Often the decision of which fluoropyrimidine to choose is multifactorial owing to the nuances of clinical practice. Potential factors that play a role in the agent chosen can include, but are not limited to, toxicity differences, institutional resources, ambulatory pump availability, etc., insurance coverage, and patient preference. Additional factors that could influence the selection of a carpacetarbine-based regimen include the presence of renal impairment and relevant drug-drug interactions, particularly concomitant warfarin use. Irinotecan in combination with fluorouracil and leucovorin has been evaluated in the adjuvant setting for stage 3 colon cancer. The use of irinotecan did not produce any benefit in terms of disease-free survival. However, toxicities were increased with the combination of irinotecan and fluorouracil versus fluorouracil alone. Therefore, irinotecan is not an agent used at present time in the adjuvant setting for colorectal cancer. In addition, some of the biologics available for the treatment of metastatic colon cancer, such as bevacizumab and cetuximab, have been studied in the adjuvant setting as well. To date, none of the biologics approved for metastatic colon cancer, bevacizumab, ramucirumab, ziv-af-libacept, cetuximab, panitumumab, or regorafenib, are approved or recommended in the adjuvant setting. BSR has extensive lymph node involvement, and this means he has stage 3C disease, which places him at a high risk of recurrence. Therefore, he should receive adjuvant chemotherapy after surgery. The goal of adjuvant therapy is to eradicate any residual, undetectable disease left behind after surgery and to reduce his risk of recurrence. The initial cycle of BSR's adjuvant chemotherapy should begin approximately 4 to 6 weeks after his surgery and continue for a total of 6 months. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 447.